Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS and Opioids, Registry Update and Safe Use Strategies. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. The 2025 Educational Webinar Series is an RLS Foundation program aimed at addressing topics relevant to the RLS community through monthly expert-led webinars. The RLS Foundation is using Zoom webinars for this program. To ensure a seamless viewing experience, confirm that your Zoom Workspace app or browser software is up to date to meet Zoom requirements. Following the live webinar, the recording will be made available for active members to view through their online member portal. If you like to view this webinar recording and are not a Foundation member, we invite you to join online today by going to rls.org. Please be aware that all attendees will remain on mute during the hour. Following this, Dr. Winkelman's presentation, he will answer as many questions as time allows. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. For help accessing the live webinar on your computer, call the office phone number listed on your registration confirmation email. For additional questions about this program and future webinars events, please email info@rls.org. Our speaker today is Dr. John Winkelman, who is board certified in both psychiatry and sleep medicine. He's the director of the RLS Quality Care Center at Mass Gen and specializes in RLS, insomnia, sleep apnea, sleep-related eating disorders, and parasomnias. He is the leading investigator for the National RLS Opioid Registry, which examines the use of low total daily dose opioids for RLS. Dr. Winkelman serves as chairman of the International Restless Leg Syndrome Study Group and has been on the Foundation's Scientific and Medical Advisory Board for 25 years. Happy anniversary. Thank you, Dr. Winkelman, for sharing your time and expertise with us today. I now invite you to begin your presentation.
Thank you very much, Carla, and I appreciate the opportunity to speak to your members. The Foundation has been an extraordinary resource for both doctors and patients for these 25 years that I've been involved with it. And I'm happy to talk today about safe use of opioids, and then predominantly talk about the National RLS Opioid Registry, which has been funded by the RLS Foundation and the Bazooki Group. So without further ado, let's start. And this is quick. We're going to really kind of sprint through this safe use of opioids. I think that there have been other talks on this, but I'm just going to cover this from my perspective quickly. If your doctor is considering prescribing opioids for you, they may do these things to assess whether you're an appropriate candidate for their use. They may administer the opioid risk tool, which is over here on the right, which assesses risk for opioid misuse and abuse. It's not really particularly well validated, but gives a general idea about whether people have a risk. And you can see you add up the numbers if you're male or female and gives you a risk score. They may check the state prescription monitoring program where you live to see whether you are getting opioids from any other provider or any medications that might make opioids less safe. They may ask you to do a urine toxicology screen to see if you are taking any other medications that in combination with opioids can make them less safe. And they may do an opioid contract or agreement, we certainly do at Mass General, to give a sense of the responsibilities that I would have as a provider and you would have as a patient taking these medications. So you can see here that was the WHO. Now we've got the what opioid, and there are a lot of options for opioids that are available. And I basically am dividing them by half-life, with very short acting ones here and longer acting ones here at the bottom. For many people who are taking opioids for restless leg syndrome, who have augmentation, they have symptoms anywhere from 10 to 15, maybe 20 hours a day. And so taking multiple doses of a short-acting opioid where the blood concentrations are going up and down like this, from my perspective, is not a wise idea. So we generally use long-acting agents, and those would be either methadone or buprenorphine, often in combination with naloxone called Suboxone. And here you see the doses that we usually start with, and then the usual effective doses here, where people end up. How do people decide which opioid would be most appropriate for a particular patient? Well, really has to do, as I suggested before, with the duration of symptoms during the day. And the first thing I do one of the first things I do when I talk to people about their RLS is I divide the day into 4 equal parts: 6 to noon, noon to 6, 6 to bedtime, let's say 11, and then 11 p.m. to 6 a.m. And I figure out how many days a week they have the symptoms during that period of time and how severe they are: mild, moderate, severe, or very severe. So I'm getting a kind of a picture of the shape of their RLS symptoms. And that way I can get a sense of what my target time is. And if people just have symptoms a few hours a day, I'm fine using a short-acting medicine. If they have symptoms maybe 6 to 10 hours a day, maybe they start at 9 o'clock, and if they wake up in the middle of the night at 3 o'clock, which is 6 hours later, or maybe 4 o'clock, at 7 hours later, well, the short-acting agent, and they have RLS at that time, the short-acting agent may not cover them. So I may need to use something a little bit bigger, longer. But if they have symptoms for 10 hours a day or more, I'm generally going to be using one of these long-acting agents. I just thought I'd throw this in. There's a nice paper that I was part of from Sergi Ferry of the National Institute of Drug Abuse, who is examining the abuse liability of various opioids. And there's some suggestion that methadone and maybe its isomer S-methadone are much less abusable because they produce much less of a buzz or a high than other opioids. Well, now we talk about dose. So let's just take methadone, for instance. If people are taking it for opioid use disorder, you can see the usual, here's from 0 to 200 milligrams. You can see the usual dose for opioid use disorder. People who have addiction problems, let's say, is around 100 milligrams. For chronic pain, about the same amount. However, for restless leg syndrome, you can see it's much lower. And we'll see the exact doses that I use in my practice on the next slide. So this is why when Carla talks about opioids, she always prefaces the word opioid with very low dose, because we really want to emphasize that this is not your usual doses of opioids. So here's my report from the state of Massachusetts, a prescription monitoring program. And they provide information about morphine milligram equivalents. And here's over a 6-month period at the end of 2024. And just if you look over here, you can see the average dose that I'm prescribing to the, how many people was it? A lot of people that I'm prescribing opioids for was 8 milligrams of methadone, 20 milligrams of oxycodone per day. So that's really kind of the sweet spot. This is for 85 patients during this 6-month period. So when I prescribe medicine for opioids, I am required by the state of Massachusetts and Mass General Hospital to meet with people, can be virtually, every 3 to 4 months. And I'm quite strict about that. And I say to people, if you can't arrange that with your busy schedule, then maybe you should find another provider who is not as strict about that. But these are the regulations. I follow the regulations so that I can continue to function as a provider and be responsible for the 700 patients I have with a variety of sleep problems. I want to make sure that I'm following all the rules. So every 3 to 4 months. Sometimes I do overnight sleep studies if I suspect that people have another sleep disorder like obstructive sleep apnea, central sleep apnea. Don't do a lot of blood tests, but one blood test, obviously I'm checking iron for people, but in addition, I will check testosterone levels, particularly if men are reporting sweating, which is one of the most uncomfortable symptoms of opioids in both men and women, is this intense sweating. I say that men can experience menopause, and oftentimes if they're having that intense sweating, it's because their testosterone is low, and then I'll refer them to their primary care doctor who will prescribe testosterone gel, and the sweating usually clears up after that. I make sure that everybody who's on methadone has an EKG to check for this particular feature, the QT interval on the EKG. Sometimes people have been doing really well on low-dose methadone or Suboxone or some other opioid for a while, and then things go south, and they email me quickly, usually, and say, I don't know why, but for the last week or two, I've been having really bad RLS in the evening or in the middle of the night, and I'm back to walking at night. And so we have to go back to the drawing board and think about all the things that can make restless legs worse, which there are a variety of them, and identify, if we can, whatever has provoked this worsening of their symptoms. I also try to have, on virtual visits through Zoom, try to have other family members present, so the partners of patients, their kids or their parents or their grandkids present, so that everybody understands the doses of the medications I'm prescribing, the context in which I'm prescribing them, and to make sure that these medications are being kept securely away from anyone who could get access to them other than people who are supposed to, and that the medications are being taken regularly as prescribed. And I say to the patients, look, we're a team here, but if you're doing things on your own, that's not your role to be playing doctor. I'm the doctor. We make decisions as a team. And if you want to lower the dose, change the dose in any way, the timing of it, let's talk about it. We can make a decision between the two of us, but I don't want you doing things on your own. And I also try to communicate with primary care and other providers where it's relevant. So let's think about the side effects of opioids. Almost everybody who's taking an opioid will have constipation. The good news is that's usually manageable. So over-the-counter things, Metamucil, Senna, Colate, those kinds of things can be very helpful. When those are not effective, Miralax, a miracle laxative, Miralax in very small doses can be extremely helpful in managing constipation. And I say to people, I really don't want you going more than 2 days without having a bowel movement, because constipation gets worse the longer you don't go. Daytime sleepiness can be an issue for some people. People will have an increase in their nighttime sleep, which is usually welcome, but daytime sleepiness can be an issue, interfering with reading, having conversations with people, watching a ball game, that kind of stuff. And we, again, need to go back to the drawing board and make sure there's no other things that are contributing to that. Itching can be an issue, although usually not a big deal, but sometimes has to be managed. And it's difficult to manage because usually antihistamines are not particularly helpful, but some kinds of ointments can be. Nausea sometimes is present, and usually that's if the dose is too high. And so I will try to lower the dose at that point to try to find an initial dose that is tolerated, and then increase that very, very slowly, because nausea oftentimes improves over time. If not, people can use ondansetron or Zofran, which can help with the nausea. I talked about sweating already. Central sleep apnea can be present, where the brain is not sending adequate signals to breathe. It's generally not dangerous, but it can interfere with the quality of sleep and produce daytime sleepiness. Here's the, this is going on to the registry now. This came from the registry. We got a lot of messages from people in the registry. This is one that we got not long ago. It's somebody whose doctors would not prescribe opioid for her. She was very kind. She says here, I find it almost cruel to deny an 84-year-old woman pain relief. And I have to say, she was very kind to say almost. Doctors are very, very anxious about prescribing this class of medicine for people. There's an opioid crisis in this country. At this point in time, it is not related to prescribed opioids, but rather to those that are being used non-prescription ways, usually with injection. And I find it extremely unlikely that this 84-year-old woman would develop opioid misuse or abuse. So access can be a problem. Opioids, this is from another study that we did looking at people with augmentation, where we would first give them, this is how I do my practice, first try to get them off the dopamine agonist with either gabapentin or pregabalin, adding that to the dopamine agonist, then very slowly decreasing the dopamine agonist over time. And if that doesn't work, then I would add an opioid. And about 40% of people were able to discontinue the dopamine agonist with just an opioid alone. So that's pretty good. It's not 100%, it's not even 80%, but it's about 40%. And it's about 40% with gabapentin alone as well. So between the two of them, and sometimes in combination, we can oftentimes get people with augmentation off the dopamine agonist. For those of you who want to send something to your providers, you may want to look up this paper, which is kind of well, you see, I got asked to write this guideline really for how to treat severe augmented restless leg syndrome in this section in this pulmonary journal called How I Do It. And I made it very user friendly. And so you could print this out and take it to your doctor and say, well, here's a step-by-step of what you would want to do. And so that may be of value. And I'll show you one more thing in a minute that also may be of value for them. This is a particularly difficult issue in people who are taking methadone who have side effects and want to try to switch to buprenorphine, that's usually Suboxone. And there's no clear method that's been established to do this well. There's a variety of methods, but nobody's quite figured out the best method at this point. This is a common question that I get asked for people who are on Suboxone, buprenorphine. which can block the action of other opioids. But at this point in time, as you can see here in the red box, a simultaneous administration strategy, continuing the buprenorphine and then adding the regular pain medicine post-surgery. Let's say you get a knee or a hip done, or some other kind of surgery, you actually can add the opioid to buprenorphine, particularly given the low doses that are used for RLS. Common question I get asked is, can you combine opioids with the gabapentin or pregabalin? And I say absolutely yes. You do need to be cautious because they have combined sedation. They have the potential for combined respiratory suppression, but monitoring them carefully. I have a lot of people who are taking both a low dose opioid and a relatively low dose of pregabalin or gabapentin. And that way, the side effects of each one, which are different generally, are lesser rather than combining one of the medications and the doses. The side effects would be larger. This is another thing that might be of value for your providers. This is a website that I developed with funding from the Bazooki Group, which is a neuroscience foundation. This is called RLS Curbside. A curbside is when you are in the hospital and you're walking down the hallway and you have a patient that you're thinking about, worrying about, and you see a doctor who's got some specific knowledge in that, and you kind of grab them and pull them to the curb and say, can I just tell you 1 minute about this person that I'm thinking about? And so it's a brief consultation. And that's what RLS Curbside is. It is only for healthcare providers. There is some information there for patients, but I think, to be honest, the healthcare information you get from the RLS Foundation is better than we have here for patients. This is really for providers. You see the QR code and you can send this to your healthcare provider. And what they can do, they register, they have to show their medical license. And then we have what's like a Reddit forum that they can put information about whomever they have questions about with RLS, age and gender and medications and when they're having RLS, what medicines they've tried, et cetera, to quickly enter that. And it goes out to the well over 200 people who have registered for curbside, who are oftentimes very experienced, who will give their educated what they would do in that particular case. I want to emphasize that for providers, this is free, and it has no commercial influence at all. I don't get paid to do it. This is kind of my idea of one legacy, that this thing would live on after I'm sipping margaritas somewhere and have retired sometime in a distant future. So now we're going to transition to the opioid registry for the last 15 minutes or so. And I know this is how you feel, it's how I feel about, you feel it about taking opioids, I feel it about prescribing opioids, kind of self-conscious about it, stigmatized, but in fact, opioids are an extremely effective group of medications, class of medications at very low doses for RLS. So we overcome this anxiety of being the fifth that's going in the wrong direction and do what's best for us as a patient or as a provider. So the National RLS Opioid Registry, the idea was to establish a large prospective study for the long-term assessment of opioid treatment of RLS. And a registry is an observational long-term study, observational, because we give no advice to anybody. We're just watching. Every 6 months, we get information from the 500 or so people who originally signed up 8 years ago, and we're just trying to get a sense of how things are going with their care using opioids for their RLS. And we wanted to determine, did the opioids continue to work for their RLS? Were the doses relatively stable? What other medicines are they needing to take or requiring to take? What are the side effects? And what are the benefits or lack of benefits for sleep and mental health? So the only inclusion criteria were that people had to have RLS and had to have had a beneficial response to a dopamine agonist at one point in time. It's kind of a proof that they really had RLS. And they had to be taking daily opioids for RLS. We did an initial phone screen, and we enrolled the 500 people over a period of about 18 months from 2017 to 2019-ish. And then they filled out a survey online within a week. And every 6 months, since people enroll, they get an email asking them to do the survey. And we've been really, really fortunate that people continue to participate. And I'm very grateful for all the people in the registry. We published our 1-year data 4 years ago. We published our 2-year data 2 years ago, and we just had submitted our 5-year data a few weeks ago. So should be hearing back from that. And I'm going to be presenting the 5-year data at this point. We already had people who were up to 7 years, but the tail end had just finished 5 years. So that's why we're presenting that now. So at baseline, you can see about 60% of people were women. 3/4 were over 60. 98% were white, and about 2/3 had a family history of RLS. Here you see the distribution in terms, geographic distribution in terms of the U.S. There's some people who are outside the U.S. who are participating as well, particularly in Canada. This is Massachusetts here, this cute little state here. And I probably have 5 or 10 of my own patients in the study, but predominantly they're from outside, certainly of my practice. About 40% had a history of depression, 1/3 with a history of an anxiety disorder. About 1 in 5 had a prior history before beginning opioids for restless legs of active suicidal ideation, an actual intent or plan to end their life. 3/4 of the people were at low risk of opioid abuse by that opioid risk tool that I described before. And here's the distribution of the opioids that people were taking on enrollment, which is what I call entry or baseline on enrollment. About 50% taking methadone, about 1/4 taking oxycodone, 1 in 7 taking hydrocodone, about 1 in 10 taking tramadol. And you can see at the time of entry, baseline, into the registry, people had been taking their opioid for a varying amount of time. The most common amount of time was 1 to 3 years, but we had a number of people who've been taking 3 to 5 years, 5 to 10, more than 10 years. And then a bunch of people have been taking it less than a year, about 1/4 of people taking it less than a year. And then here's some dosing information at baseline, at entry into the registry. People were taking an average dose of 7.5 milligrams of methadone, 20 milligrams of oxycodone. So you can see that even though only a few of these patients were mine, this is kind of the usual dose, because that was almost exactly the doses that I use in my practice. About 80% of people were taking a methadone dose of 12.5 milligrams or less, or 33 milligrams of oxycodone or less. 17% of people, 1 in 6 people, still reported they were having severe or very severe restless legs. Here you see a graphic distribution of the morphine milligram equivalent, and most people way down here at the low end of dosing, the very low opioid dose, but with a few people at the higher end. And here's where we were as of a few months ago. See, we started out with 500, and over time, we've had some people who are no longer in the registry. And as of 5 years, this paper that we just submitted, we still had 410, which for these kinds of registries is extraordinary. Just amazing, the loyalty of people in the registry filling out surveys. I have to say that we nag them if they don't fill it out, and we send emails. And then if they're more than 2 months behind, they get a telephone call from John Winkelman, and I say, hello, how are you? And chat with them about what's happening. And sometimes people have been traveling, sometimes they've been sick or in the hospital, and just try to encourage them to continue their participation. Out of the 500 at 5 years, 18 had died. 38, which is the largest group of people, had stopped their opioid, oftentimes not of their own choice, but because their doctor moved or retired or decided, or the new doctor wouldn't prescribe it. 9 people said, I'm done with this, and 20 people just lost in the wind. And here you see the dose changes from baseline, it's entry into the registry, to 5 years. Largest percentage of people, 30% of people, were unchanged. But you can see if you add up all of these dose increases, about 50% had increased their opioid dose. But generally, those increases were quite small. So half of the people who increased their dose had increased it by a more methadone dose of 2.5 milligrams or less, or an oxycodone dose of 6.5 milligrams or less. We did have some large increasers here, and those are the particular people that we are focused on. One of the things we're focused on in this registry, who need to increase their dose quite a bit, and can we predict those people moving forward. We also had about 20% of people who had decreased their dose from baseline. And when we specified particular opioids, you can see at baseline, we had 202 people taking methadone at baseline, 218 at 5 years, and the baseline average dose was 10.9 milligrams. At 5 years, it was 12.5 milligrams. So very, very small increase. One notable thing is the biggest group of increasers was buprenorphine. 14 people when they entered the registry, now 45 people at 5 years. So buprenorphine is kind of a up and coming, gaining some popularity, opioid for restless leg syndrome. What's interesting is that people who, when we looked at the doses of the people who were on buprenorphine, about a third of people had decreased their dose compared to the previous medication, but a quarter of people had substantially increased their dose, and a half of people had increased it by a decent amount. So that's just something to keep an eye on. And then we did this little thing that we used this what's called a trajectory model. It's a statistical technique where you can identify groups of people that belong together. And in this case, we use trajectory analysis to identify changes in opioid dose from baseline 0, 1, 2, 3, 4, 5 years. And you can see that the largest group by far were these people who had no or little change in their opioid dose. That's about 3/4 of people. About 20% of people had a small increase in their opioid dose over the 5 years. And a very small number of people, and this was actually like 13 people in the registry, had a large increase. And we were particularly interested in what distinguished this group from these other groups. And one way we looked at it was by looking at this large increased group here and the percentages of people who had various features. And you can see that the most common feature in this large increased group were people who had switched from another opioid to buprenorphine. Almost 50% of people of the 13 had switched to buprenorphine, whereas in those other groups, the small increase or the no or little change, it was much, much less people, fewer people who had switched to buprenorphine. So that's the predictor. People who had switched to methadone had also had an increase in their morphine milligram equivalent dose. So people who are switching to these long-acting agents do seem to go up to a higher dose. And there are also people who had severe RLS at baseline, were much more commonly represented in this large increased dose, which makes sense. People whose RLS is really bad are going to need to increase their dose. If you look at the 410 people who we evaluated at 5 years, you can see that there were minor changes in RLS symptoms. So there were less people who had no RLS symptoms, more people who had mild. It looks as if some of these people here, baseline who had no symptoms, now have some mild symptoms. But in terms of people with moderate symptoms, little change from baseline in blue to 5 years in orange. Same with people with severe or very severe symptoms. They really didn't change the number of people. I'm going to skip that here. Let's talk about side effects. You can see at baseline in 5 years, a little bit less, fewer people with constipation, about the same number of people with fatigue, same number of people with itching, and about the same number of people with sweating. But these are the most common side effects that we hear about from people in the registry. We are particularly interested in the concern that people with restless leg syndrome have suicidal thinking or actually even plans or intentions. And we look at this in the population of individuals in the registry. And you can see that people who were on methadone had about 2.5 times less risk of suicidal thinking than people who were not on methadone, were on some other opioid for RLS. I don't think that, the question is why is this? Why are people on methadone less likely to have suicidal ideation than people on other opioids? And so we did something called a mediation analysis, where you try to find cause and effect. As I said, there's a strong relationship between methadone and decreased suicidal ideation. And it seems to be because there's a strong effect for methadone, substantially decreasing the severity of RLS symptoms. And with a less severe RLS, there's less depression severity and less suicidal ideation. So that seems to be the causal chain there. So this may be my last slide, reminding you that you can give this information to your healthcare provider, your primary care doctor, or your neurologist, or whoever is providing your RLS care so that they can register if they're interested and put up a post with questions that they have about you or any of their other RLS patients. And hopefully they'll get a number of responses from the community giving suggestions about best practices with the specifics that they have provided on curbside. I want to thank the RLS Foundation. Carla has been a steadfast supporter. When I first presented this to the board, I got a lot of what? You want to do what? How is that gonna blah blah blah? And I just kind of I think this will be of value. And Carla was a great supporter from the beginning and continues to be. I also want to thank the Pasuki group and also thank the colleagues who referred their patients to the registry. Many of them also came from the foundation, and to the participants nationwide in the RLS registry. So thank you. I'm going to stop sharing so that you can see Carla here in the big screen.
All right, well, let's move on to the question and answer section. First question, is Sublocade an injectable form of buprenorphine being used for RLS?
It probably is by somebody. I have never used it myself, but I think that at least in the registry, we haven't heard from anybody who's using it. So maybe in the future, but at this point, no, there are a variety of different ways that buprenorphine can be administered. Usually it's under the tongue, but you can also apply once a week patches. So I haven't heard anything yet about Sublocade for RLS.
Which opioid is best to assist with dopamine agonist reduction or elimination?
That is a decision that is made between you and your doctor. As I suggested before, I make that decision based upon the number of hours of symptoms that you are subject to. If you sit down, lie down in the afternoon, in the morning, in the evening, overnight, how many hours a day do you think you are vulnerable to RLS? And then I will fit the medication to the size of the RLS that you have.
It is cautioned methadone can worsen asthma. If Horizon is not adequately managing symptoms, are there any risks of adding low-dose methadone in a patient with asthma?
Potentially, although I've found that this is really would be a rare risk. You know, people with asthma can get tightness in the upper airways, so they're struggling to breathe. If they have a bad asthma attack, so somebody with bad asthma, I would be cautious about, but otherwise, no, because the nice thing about asthma is usually inhalers take care of it pretty quickly. And methadone's effects are not on the upper airway, but are on the drive to breathe, if they have any effect at all at these very low doses. So mild, even moderate asthma, I think you're fine. You know, you just have to have an inhaler around.
Is there any strategy for alternating the use of different opioid medications in low doses to decrease tolerance?
No, I don't think that that'll be really of much value. I think the thing to do is to find the optimal opioid at the optimal dose, and then make sure all the other things that can worsen RLS are under as best control as possible, avoiding serotonergic reuptake inhibitors. So that's a lot of the antidepressants, avoiding dopamine blockers. Some of those are used in depression, they're used in gastrointestinal disease. Make sure that you're not sitting around too much. Make sure you're not taking antihistamines that work in the central nervous system. Make sure you're getting modest exercise, but not overdoing it. If you have sleep apnea, treating it. Certainly if you have low-ish iron, getting oral or IV iron. Those are really the key elements in keeping the dose of your opioid stable.
Which opioids are considered safe and which are considered too risky for use?
All opioids are risky, just by their
Mhm.
nature. If you take too many of them, it's a risk. And so you need to assess whether you're someone who can use these medications responsibly. So I don't think there's any short or long-acting opioid that's any more or less risky than any other one, honestly. Really, it has to do with the dose and keeping the dose low, which really shouldn't be a problem in RLS because doses are generally quite low.
What medication and treatment strategies are safe and effective for bedridden or terminally ill RLS patients?
I would say in people who are terminally ill, I would use, so that they are bedridden, can't get out of bed, to get rid of symptoms the way most of other people could, you're going to probably need to use somewhat higher doses. If they're terminally ill, they may be getting opioids for whatever terminal illness they have, and so making sure that they don't have interdose rebound. So that's a problem. If you have a medicine that lasts 4 hours, you go up and then you go down. And if you're waiting 6 hours till the next dose, then you have the potential for 2 hours of bad RLS as the opioid wears off. You really have to be attentive to that and think about how long does this medicine work, and you really want to overlap each dose so people don't end up in that trough with restless leg syndrome. Bedridden, same thing, and I have a number of people with bad MS who have a ton of difficulty with mobility, and they may need to be on a little bit higher doses because they're doing the things that normally most people would do to get rid of minor or even moderate symptoms, walking around, standing up for a little while, they may not be able to do. So thinking about that, I think, is valuable in those people.
Do prescription opioids present any risks when performing tasks such as driving?
An opioid can make people sleepy. And certainly, the first time you take the medication, you should make sure for that week or so when you start, and if you change your dose, that you're not going to be driving or, as they say, operating heavy machinery. I never know exactly what kind of machinery they're talking about. I don't know if they mean like a blender or if they mean some kind of giant thing on a farm, but nothing where you could get in trouble if you nodded off. But I think in general, you need to use best judgment, talk to your doctor about that, ask them whether they think you're at risk of falling asleep while driving, and if so, then use extreme caution. By the same token, obstructive sleep apnea presents a substantial risk and probably more of a risk for daytime sleepiness. So you really want to make sure that if you're at risk for sleep apnea, that you have a sleep study and you're managing your sleep apnea as recommended by your provider.
I've lost my appetite and I'm nauseous when eating on methadone. Are there any remedies for this side effect?
Yeah, that's a tough one. We presented an abstract this year or last year, I can't remember, on people who had lost a substantial amount of weight on an opioid for restless legs, and low doses. And it was very concerning to them, very concerning to their provider. They got $1 million workup to make sure they didn't have cancer and didn't have cancer. I think that sometimes people's appetite does improve over time being on the opioid. Sometimes it doesn't. You may need to try to lower the dose. There are some appetite stimulants that you can take, although you want to make sure that these are not antihistamines because those can worsen restless legs. And just, eat a lot of Haagen-Dazs, and as long as your cholesterol will survive that, and sure, my experience is people lose a bunch of weight, and it can really be a bunch of weight, like 40 pounds over a period of a number of months, and then plateau at a new level. And it may not be the level that they prefer. And if it becomes significant enough, you may need to switch from an opioid to a non-opioid treatment like pregabalin or gabapentin, maybe even back to a dopamine agonist if nothing else works, because you do need to maintain nutrition.
Can opioids cause trouble focusing or dizziness?
Yeah, I mean, opioids can produce daytime sleepiness. And if you're sleepy, obviously you can't focus. You need to be awake, to be an alert, to attend. And so, yes, that's possible. Dizziness, maybe. I haven't heard so much about dizziness with opioids. I hear more about that with gabapentin and pregabalin, where you really do need to be careful if people have limited mobility issues, either because of neurological disease like Parkinson's, MS, or bad neuropathy that makes people more prone to falls. But I haven't heard so much about dizziness with opioids, but certainly if it makes you sleepy, it's going to interfere with focus.
Are there any long-term side effects with OxyContin?
I would say that the long-term side effects are really similar to the short-term side effects. So what you get early on is probably what you're going to get later on. Sometimes, as I said, those side effects can improve, nausea can improve, itching can improve, appetite can improve, sleepiness can improve, but I really haven't seen a surprise over the long term with the opioids. You do need to keep an eye on if you are having sweating, either men or women. Keep an eye on testosterone because that opioids interfere with the production of reproductive hormones, and so that's something that can happen later on versus immediately. And a sign of that can be sweating, or can be other things like kind of apathy, a loss of libido. So those are things that may happen over time. But in my experience, the short-term side effects and the long-term side effects are roughly equivalent. No surprises out in time.
We have a question. My RLS is worse during the summer. Is there a reason for that?
Maybe that's why I've been getting so many emails and pages over the past couple of weeks. I don't know what's going on. I don't know the phase of the moon. The funny thing about restless leg syndrome is I say that it's fickle. And everybody who has it tries to figure out, why did it get so bad last week and now it's better again? And people are always racking their brains about this. Was it what I ate? Was I not drinking enough fluid? Was it because I walked 10,000 steps and not 7,000 steps, or 3,000 steps and not 7,000 steps? And so it's just as fickle. It just changes a lot. And there may be a time of year or seasonal effect in restless legs. I don't think that's well established at this point, but in general, RLS just kind of goes like this: worse and better and worse and better. And hopefully we can just minimize it so it's not big swings, but small swings over time.
We have a lot of questions about access to opioids. So in general, why are some pharmacies denying access to opioid prescriptions, as well as insurance companies, and what can they do about that?
Why people do bad things is a very old question. So why insurances or pharmacies won't pay for this class of medicine or provide it, I don't know. If you have a pharmacy that's really difficult, I would say try to switch pharmacies, and people have been successful with that. With methadone, which is the most common opioid that I prescribe, oftentimes people will need a prior authorization. And what I found is that after all the work of everybody doing the prior authorization, instead of a copay of $10, the out-of-pocket payment might be $12, or sometimes it's less than the copay, it's $7. So if you're having trouble getting insurance authorization, you can ask the pharmacist, you know, if I just paid for this out of pocket, how much would it be? And you're going to be oftentimes, I think, very surprised at how inexpensive methadone is if you just pay for it out of pocket. But access is an issue. And it's not because the pharmacists are mean people. They've got people breathing down their neck, just like doctors have people breathing down their neck about the prescribing or providing, if you're a pharmacy, these medicines. And so you can switch pharmacies, maybe you can switch doctors, you can ask about paying out of pocket. Usually people can get access to an effective opioid just by trying a few different things.
Now we're going to switch into alternatives for opioids. Is there evidence to support using stellate ganglion blocks as a treatment for severe RLS in the upper torso and arms?
Not as far as I know. Maybe there's one case report for stellate ganglion block, but there's no good evidence, I would say. But if people are really bad, have really bad symptoms, they will try anything. I understand that. And it's worth it as long as you consider the risks and benefits.
If low-dose opioids are no longer effective at controlling symptoms, what is the next line of defense?
The next line is always back to the drawing board. Low-dose opioids are effective for really almost everybody. And so you really need to start thinking dirty if they're not working. And you need to go back to the drawing board and think, what else is making this worse? What else is making it such that the opioid's not working? And there are a number of possibilities, as I mentioned before, and hopefully as your RLS specialist is aware of all those things. But the alternatives to opioids are gabapentin or pregabalin, certainly oral or IV iron. Those are really the main ones. Some people are using the NIDRA device, the transdermal electrical nerve stimulation device that people put on below their knee. And then there's some other medications that can be of help. Dipyridamol has evidence in its favor. Beyond that, the medication options are really uncertain. Occasionally people will use benzodiazepines. Occasionally people will use clonidine, low-dose naltrexone, but I'd say that the evidence there for all of those is not great.
Right, before we let you go today, we'd like to know about what you have in the hopper as far as research that you're working on for RLS.
I wish there was more, but there are a couple of companies that are developing new treatments for restless leg syndrome. They're certainly not approved at this point in time, but if phase 2 and phase 3 trials are successful, I could imagine within a year or two, probably more like 2, we may see some new agents on the market. You know, as you can imagine, Carla, I'm out there trying to talk it up as much as possible. Drug companies, though, want billion-dollar drugs. They once blockbusters. And there are a lot of people with RLS, but there aren't that many people with RLS. But I think now that the physician community recognizes that dopamine agonists are really not a good idea unless nothing else is working, people will be moving away from those. Providers won't go there certainly as a first choice. And that provides an opportunity for drug companies to make money, because now the dopamine agonists are kind of are not first line, so we have less first line agents. So that provides an opportunity for the drug companies with these new medications, maybe to, if they're successful, to make money. And you can't blame them. That's what they want to do. But so I'm hoping that in the next couple of years, we'll see something that, and so I'm involved with kind of supporting the companies by helping them devise the treatment protocols. In terms of my own research, we're doing a lot of stuff with the UK Biobank, looking at large cohorts of people because there's RLS information now in the UK Biobank. And in the UK, they have 1 million people enrolled in this study. I thought I got a lot, 500. UK Biobank has 1 million. So that's an opportunity to learn more about RLS. And I'd say those are kind of the highlights at this point.
Well, thank you so much. We appreciate you taking time out of your day to give us a nice update on the RLS Opioid Registry, and also about safe use strategies. And I invite everyone next month to join us with Phil Goglass, who's Dr. Winkelman has worked on the in Washington, D.C. on the Hill, to go around to different offices to advocate for RLS. I hope that you'll join us. There's so much going on in DC. It's a nice snapshot to see where we are and what we're going to be working on for Hill Day in October. But thank you, everyone, and have a great afternoon.
Hi, Carla.
All right. Bye-bye.